Yeah, so I'm really right person right now at present in this particular scenario when most of the people are sleeping. Anyway, so in 1997, actually, I came over here and passed my DNB exam from SCPGI. And since then, I'm in love with this department and their HOD. So thank you very much, Dr. Ansari, for opportunity and love. Yeah. So, and I will take a couple of more minutes because my topic is controversial and somebody reduced my time actually. No issues, but so I will quickly go through this theoretical part. It's a slow urinary stream, hesitancy and straining to avoid with the or without feeling of incomplete bladder emptying and dribbling. And low, further characterized by the low voiding frequency during the day, which is equal or less than 3 times per day, and associated with the large amount of post-void residual urine and high capacity bladder in sonography. And probably this is the only LUTD in which urodynamic testing is normally recommended as a part of initial workup. And it characterized by the detrusor contraction of reduced strength and or duration, resulting in prolonged and incomplete emptying. So it is essentially a micturition pattern. Etiology can be neurological, idiopathic as a sequel of the OAB, overactive bladder, hypocontractile detrusor by birth, suppression of voiding, long-term suppression. It can be myogenic and iatrogenic. I will be mainly focusing on idiopathic. So underactive bladder, the diagnosis is a bit difficult in that way that we have to go through the extensively from the clinical history, physical examination. I believe in bladder diary, and we all have to maintain for this kind of a lower intake dysfunction bladder diary. Ultrasonography with post-void residual urine, uroflowmetry possibly with the EMG, and in required patients with MCUG and video UDS. I agree with the previous speaker as well as the Dr. Ansari for use of MCUG in a suspected case of lower intake dysfunction before we go ahead with the other investigations. This is history. I'm not going to go in detail, but we should know about the urinary frequency, hesitancy, all these things. Holding maneuvers, whether the children is habituated with these holding maneuvers, various constipation. Specifically, if other histories are not received, then we can ask that how frequently the child is passing stool in a week. If it is fewer than 3, then it is considered also constipation. But we have to give a lot of attention to this. And in addition to that, we have to look at the child's psychological development, particularly with the respect of stress event, anxiety, excessive shyness, aggressiveness, oppositional behavior, and various other things. So all these things should be taken into consideration. And that is, I tell you, very difficult in the place where I am practicing, because in a very congested OPD, it's very difficult to find out all this time. And it's very difficult to train the nurse also for all those things. And in examination, then you have to look for the distended bladder, palpable fecal mass in abdomen, and sometimes you have to put your small finger into the rectum to see the rectal ampulla. Complete examination of lumbosacral spine and cremasteric and anal sphincter reflexes. Most of these cases in my setup comes with urine tract infection, so urine examination and culture, serum creatinine, as we see in almost 2/3 patients renal deterioration. Ultrasonography, it should be between 50. How much volume? 50 and 150 percentile of the expected capacity of age. We'll come to the expected capacity. And post-void residual urine volume should be measured in the first 5 minutes, preferably first minute of the micturition. Now, any post-void residual urine volume, which is more than 20 ml on more than one occasion, is considered abnormal. And bladder wall thickness, which can be also measured very well with the sonography, and in empty bladder should be less than 3 millimeter. And in constipated children, the rectal diameter of more than 3 centimeter considered as a clinically significant. In addition to this, we can look in sonography upper tract conditions, whether the upper tract is dilated, hydronephrosis, bladder diabetically, bladder neck elevation, and as well as some idea about the posterior urethra. Uroflowmetry, preferably with the EMG, uroflowmetry results showing a voided volume at least 50 ml or 50% of the expected bladder capacity of the age. What I use these two equations, age in 1 year is age in years plus 1 into 30, or Koch formula, which I have used for long, that is age plus 2 into 30, are considered adequate. Koch formula gives little more room for the high bladder capacity in compared to the first one. We all know it is very simple to perform. And if I miss to speak about this uroflowmetry and go ahead, I think Anita will kill me. Because once it happened, we discussed the entire spectrum of the wall in 2014, and we didn't talk about the uroflowmetry. And I see raise that objection. So it's very simple to perform: voided volume, voiding time, maximum flow, curve pattern, and rate of the flow. As I'm talking about the underactive bladder, this is the typical pattern which we see in a patient with the underactive bladder, where the curve reaches to the baseline in compared to the other patterns. And we'll not go much in detail about the UDS, but without doing UDS, it is very difficult to give the diagnosis of underactive bladder. So this is the classical MCUG which I see in my practice, that expected capacity in this particular patient was of around 150 cc. But you can see that the bladder volume is increased, bladder not trabeculated, high grade vesicular reflux, and almost fell to void. So you can't assess the urethra here. So this is the most common MCUG which I see in underactive bladder patient in my practice. Then comes to the bladder diary. Bladder diary is used to record urine output and frequency as well as fluid intake, any occurrence of the urgency or involuntary urine loss. With that, the bladder diary maintained over 2 or 3 days. Sometimes it is not possible to maintain it for continuous 2 to 3 days. In that case, it is not necessarily kept on a consecutive day. It can be also done in another way. The color of the urine is also routinely evaluated to assess the patient's state of hydration. Constipation, not going to go in much detail about this chart, but its presence is seen almost in 7 times more possibility of LUTD with the severe constipation. So coming to the treatment of underactive bladder, there are no drugs currently, according to my thinking, which we don't have in market any treatment, pharmacotherapeutic treatment for underactive bladder. Then the combination of measures which generally required is urotherapy, void every 2 to 3 hours, or on need, or no holding, fluid intake, avoid caffeine, chocolate, position to void, and defecation. We have to address this, and treatment for constipation. Next is the biofeedback, or along with this is a biofeedback. Clean intermittent catheterization is the main component of my practice. Use judiciously, but empirically alpha blockers and TENS and D. At the end, I conclude the therapeutic response to these measures, however, many of the times uncertain. So, but now I'm going to discuss this case, and it will be raised a lot of controversy, and that will help me proving my presence here. So this is an 8-year male child presented to the pediatrician with recurrent febrile events since 3 months prior to present in OPD of my OPD. So UTI was confirmed on culture, was treated multiple times for febrile UTI. Pediatricians noticed voiding difficulties. Parents were not complaining. Low volume urine output and distended bladder were noticed. Was kept on PUC for a couple of weeks by first urologist. So he referred to the urologist. The urologist put a catheter and was kept on the IV antibiotics. Had severe constipation. Post-word residual urine in 2 USGs were different. In first, it was 220 cc, and in second one, it was 30 cc. Serum creatinine was 1.3 milligram when problem started before a year. And urine protein was absent. Focal neurological exams were normal. So this was the first, this was the USC. With this USC, patient came to me. This was done in October 2020. You can see that bilateral hydronephrosis very well depicted into the renal level as well as at the bladder level, posterior to the bladder, juxtavesical. You can see dilated ureters and thin. Bladder wall is not very much thick, but it is definitely distended bladder. So the urologist conducted the VCUG. It was done on 27th of October, which is suggestive of a very much dilated bladder, distended bladder. The reflux in both the ureter, massive reflux, but still not reaching to the kidney. And patient failed to empty the bladder. Urethra could not access because of that. And there you can see, in spite, he has not passed much of urine, means which can assess the urethra, but he could pass a little bit of urine. We can see here, the reflux is still there. But in the last plate, the reflux urine rapidly came back into the bladder. So keep this in mind. This was uroflowmetry. These pictures were provided to me. So sorry for the hazy picture, but this was the intermittent flow. This was a urodynamic done by the second urologist. So after the first urologist treatment, patient went to the second urologist. He advised for the uroflow, urodynamic at this particular juncture, where the patient was almost having a retention or very much severe difficulty in passing urine. I think this urodynamic is not much conclusive. What I could conclude from this is that detusor is hypocontractile. Patient is unable to void. There is some abdominal straining, and the residual urine which they have noticed is 402. So again, the question here comes is that this post-void residual urine is because of obstruction, because of failed detusor, or because of rapid refilling of the urine, which is reflux to the upper tract, or it is combination of all these factors or one or two factors. So his MRI was also done by the second urologist, normal reported. And there you can see, this is for junior residents sitting into the audience. Please mind this. This is the renal scan of this particular patient. This was done after the 5 months of he was noticed with the fever. But you can see the changes here at the lower pole, here at the upper pole. These are the loss of uptake with the loss of contour. There is no uptake with the loss of contour, which are representative of scars. And there are a couple of photopenic areas, less uptake areas, without loss of contour, which is representative of acute infection or inflammation, which is either going on or was just happened in a couple of weeks. So this renal scan is very much representative of scar, certain element of dysplasia even, and the ongoing inflammation process. So though patient is presented since 5 months, but this renal scan gives some idea because of scars, which are very typical of scar, it's not dysplasia, that this patient was having probably some kind of infection which was not noticed, and pyelonephritis in the early childhood. So reflux might be there, or some events are there which is leading to the pyelonephritis. So then comes to the, when patient presented to me, the clinical findings were like this. Patient was having a fever with high grade. Patient was almost in retention, small quantity and infrequent voiding. He was in a sepsis. Urine was full of pus cells. PUC was, I again inserted the Foley's catheter of a smaller size. Patient was put on IV antibiotics according to sensitivity, and his day and night output was measured once IV filled stopped. I wanted to get idea that how much this child is consuming and how much the output into the day as well as how much the output in the night. So now here comes the controversy or some discussion. Focus it. We'll discuss sometime if time remains with me. What is the diagnosis? In this case, I proposed a case of lower unit tract dysfunction, which is underactive bladder here, leading to the secondary bilateral high-grade dilating reflux with recurrent pyelonephritis. Or the second possibility, a case of LUTD, which is underactive bladder, precipitated by the primary bilateral high-grade reflux, which has remained untreated. And because the reason is that because lack of complete bladder emptying is responsible for this, because there is a rapid refilling of the bladder. So bladder is exposed to the rapid refilling because of high grade reflux. Bladder never get that required rest. It was getting filled with the some amount of 50, 60 or 70 ml of saline, this urine immediately after the completion of voiding. And that was not giving enough rest to the or recycling of the bladder. Maybe leading child to more frequently. When he started going to school, he was trying to hold it. Again comes the holding maneuvers and gradually diffuser underactivity. And this was compounded by the constipation and recurrent urinary infection. So when I went through the literature, this is proposed by the Abrahamson's group that either these children are born with the weak bladder, which is less likely, and then they develop a secondary reflux, or else there is something like infantile voiding patterns, and over a time the contractions are inadequately inhibited by the CNS in these particular patients, like patients like this, which lead to the urgency, which is the most common type of incontinence, leading to the holding maneuvers, diffuser underactivity, clinically manifested by the underactive bladder. Essentially, we can sum up that another way it is overactive bladder to start with, voiding postponement. There may be or may not be reflux, but overactive bladder, voiding postponement, diffuser underactivity, and full-blown underactive bladder. The another, you can say, the philosophy is also available in the literature, and I also strongly believe is that it was described by the Dr. D.V.S. Desai, Great Ormond Street, and from where from other articles, that again, which we have discussed, the secondary rapid refilling from the upper tract due to the VUR, no complete emptying, no rest to the bladder, very frequent voiding sensation, voiding postponement, leading to the diffuser underactivity and full-blown underactive bladder, diffuser and underactive bladder. And here you can see, again in MCU, this is of another patient, not of this patient. There you can see at the end of voiding, the entire urine, which is reflux, massive amount of reflux urine has come back to the bladder, and the bladder is never at rest. So this could be the culprit. So how I manage this case? Urine output as well as the fluid intake chart was maintained. Expected urine output was 1 to 1.5 ml per kg. He was hardly of 18 kg. His intake was around 1.5 liter. Average output was 1.5 to 1.7 liter. Now out of that, he was throwing 1 liter in the night. So I put the patient on intermittent catheterizations to effectively empty his bladder at low pressure and with a nighttime catheter. Antibiotic prophylaxis after the therapeutic dose, bowel management. With that, this is the sonography, how the patient responded. You can see the significant reduction in hydronephrosis, significant reduction in the post-void residual urine. And this is the MCU, which was done at 5th month after the treatment initiated. You can see that the reflux is still there. It is massive reflux, but much now clear. It is reached to the kidney because the probably kinking is reduced. And secondly, we can see the urethral filling. He passed voiding, he passed a significant amount of urine. We can assess the entire urethra. The urethra is absolutely normal. So obstruction is out of question in this patient, any kind of it. So then comes the, but still significant residual urine. So we continued the treatment, and this was the repeat urodynamic was done. I declared that urodynamic facility as well as renal scan facility is not available in the place where I practice Junagadh. So patient I have to send to Rajkot, and many of the time I have to rely. Though I communicate a lot, but I have to rely what the report they are feeding to me, right? So again, according to them, some improvement is seen. You can see that here. Some rise in the pressure is there. And then you could void. Also, you can see that. This is the vesicle, this is abdominal, and here you can see. So some improvement it is showing. So further, we continue with the same treatment, but our issues were that patient came with a breakthrough for febrile UTI. Required admission, IV antibiotics, we desired, and then we decided to fix his high-grade dilating reflux by anti-reflux surgery. Patients, I just very clear it, the patient's eGFR and the creatinine were normal. Bilateral modified polynitrate bitter implantation was done with long-term suprapubic catheter for ensuring bladder recycling. So how we did, in the first 3 weeks, we kept the SPC open. For another 3 to 4 weeks, we were closing the SPC in the daytime. Nighttime, we were keeping it open. In the daytime, whenever he miss after 2 to 3 hours, he has to pass urine. We open the SPC and see that we are emptying the bladder completely, and we were noticing the post-word residue urine. But by this way, we are ensuring that the bladder recycling is done. Means bladder get complete emptying and some rest. So after another 3 weeks, as patient was responding, we started keeping the SPC block even the night. And that has started working. We were asking to awaken the child for once or twice in the night. And that is how it has started working. And gradually the post-word residual reduced. There were no febrile episodes. And we kept antibiotic prophylaxis laxative, continue with this. And there you can see the sonography further. This is the post-reimplantation sonography, right? Again, post-word residual is very much less, and the hydrouretronephrosis significantly reduced. No febrile events. So this third MCU, which we have done in 2011-21, after the year, just on the request of the parents, because parents suffered a lot. They wanted to know that whether really reflux is fixed or not. But it gave me information that it is far, far better than the first MCU, which was done by the first urologist. And then you can see this is the recent uroflow, and this is how now the child is voiding. So my presentation is open for question and criticism for the management. Thank you. And last slide, we have in literature, this kind of a case is treated. This is another case which is taken from the literature, treated with a similar way, but they did a sting procedure, which Malik was telling. But Malik, that this patient recovered from the uropathy, and thereafter they did a sting to treat the reflux. And this is the statistic which I very quickly share. Though I am in a peripheral practice where urodynamic is not available, but we are very much welcoming these patients. It's very difficult to treat these patients, but we welcome these patients. Though we don't have a very large number of patients, but in 20 years, we have seen 146 neurogenic bladders and 42 non-neurogenic bladder. Out of these, underactive bladder, we have seen almost 12 in the non-neurogenic group, and 10 patients were having associated VUR, and all patients were presenting with recurrent urinary tract infections, and all patients were having a renal scarring. Thank you.